In terms of success rates, I tell everybody 85% of patients will just need one treatment. This is over 5 years, where we have very sure data in lots of patients. 10% of patients will need a second treatment. And in the first year or two, that can be within field. And then beyond that, it will be maybe because this lesion progresses. And patients are very comfortable with that. And then I say, just like in surveillance, this is a strategy to preserve your prostate. And if it makes less and less sense to either of us, we'll need to be prepared to cross over to surgery or radiotherapy, both of which are possible. And obviously with surgery, this individual will get a normal dissection down the left, normal dissection at the bladder neck, because we're not going anywhere near that, and a normal dissection at the sphincter. Here, it might be a little bit sticky, but it won't affect the outcomes. You know, you wouldn't do a nerve sparing necessarily if you've got tumour abutting. In terms of functional outcomes, I tell men that they won't be incontinent. The risk is about 1 in 200, maybe even less than that. And I tell them that they will have a 90 to 95% chance of keeping erections sufficient for penetration. And that's based on the 2 studies we've published using high-intensity focused ultrasound. But a third of patients will require some Viagra or equivalent for a while after. And those odds are very kind of highly valued by patients. Obviously, if they have bilateral clinically significant disease,
not an ideal candidate.
Unless, you know, they've got ulcerative colitis, they've had lots of previous surgery. There's nothing to stop us treating bilaterally. We used to treat the whole gland, as you know. But you start eating into sexual function a little bit, and the opportunity for misses increases. You know, the cleverer you try to be, the more opportunity there is for getting a miss. But one of the great things about focal treatment now is more time to really dose that part of the prostate heavily. So in the past, we used to have to spread the energy, you know, across the whole prostate, which is swelling and moving. Now we really concentrate the energy to a relatively small volume of tissue and get really good overlap. And it's really rare now for my radiologists, who are very critical, if they see a post-HIFU MRI that they don't like, they'll say inadequate treatment. Really rare to see that now. It's normally good, confident necrosis with nice margins.
And how long do those typically take, the procedure?
An hour, typically. Yeah,
okay.
Yeah.
Obviously,
I mean, it depends. HIFU depends on the volume of tissue that you're treating. We tend to overlap quite a lot of treatment, and obviously it depends on the length. Usually, it's the length of the lesion that you're treating. So it's how much apex to base treatment that you're doing.